Now we are going to study about the interior of the abdomen or abdomen cavity. So that's the point for learning today, is that this is what we are going to cover in abdomen, like the coverings of this abdomen cavity and that abdominal organs and abdominal space or that particular region of the abdomen have got like some modifications of this particular covering. We call them as peritoneum modification that we are going to learn today, and as well as the clinical thing related to it. So, this is what we are familiar with regard to this particular abdomen. So, we have learned about this similar kind of cavity existing in our body, which is known as this the pleural cavity or this particular thoracic cavity. So, likewise this particular thoracic cavity in the abdomen as well, we have this abdominal cavity existing to it. So, it has a limit of the abdominal cavity, above it is lined by this or limited by this particular muscular partition, we call them as the diaphragm. And the lower part of this particular region, abdominal cavity, as it drops down here in this region, we call them as pelvic cavity. So, lower limit is formed by this another partition, we call them as pelvic diaphragm. So, from this entity, from this diaphragm to this particular pelvic diaphragm, we have this particular entire thing, we call them as abdominal cavity. Now, this abdominal cavity continues with this particular region of the pelvic region, which holds a cavity in here, we call them as pelvic cavity. Between the abdominal cavity and the pelvic cavity, we do not have any partition or any physical thing is not separating that in between this abdominal cavity and the pelvic cavity. We have an imaginary line existing on it, presented or represented at these particular white dots, which basically imaginarily separating this abdominal cavity with this pelvic cavity. Now, this inside to this particular abdominal cavity is lined by a membrane. We call this membranous structure as peritoneum. Now, that is the point of interest for us to discuss about this peritoneum and the modifications or alterations or this clinical thing related to the peritoneum that we are going to do. Now, to talk about this particular abdomen cavity, which we will be restricting our discussion on to this particular part, which is limited by above by diaphragm and this imaginary line over here into this particular region today. The pelvic cavity and this changes or modifications of this particular pelvic cavity will be covered in a separate class. We will be talking about the pelvic cavity and modifications of the pelvic cavity related to this peritoneum or peritoneal fold in the pelvis. So, in abdomen, in next 3 weeks or so, we are going to talk about the abdominal cavity, organs, etc., which is related to it. Now, so far we have done this particular walls of the abdomen we are familiar with. We have this particular abdominal wall, anterior abdominal wall. Posterior side we have this posterior abdominal wall, and on the lateral side we have this lateral abdominal wall. That is what we have learned. And we learned about detailed thing about anterior abdominal wall in forms of muscles which are contributing, and the muscle tendons we call them as aponeurosis, which are flat tendons, and they are reinforcing this anterior abdominal wall. And within this particular modifications of this particular aponeurosis, we have these muscle fibers which are present in it, we call them as rectus abdominis. So, we have done the dissections and we learned about this nerve supply to the sensory and motor to them, and how this particular abdominal cavity or abdominal muscles are contributing to the respiration, that is point of concern for us. Like normally we have an assumption like in the respiratory movement we have this thorax or chest wall is contributing only. But in case of this particular situations where we have this particular abdominal muscles or abdomen as well contributing that respiratory movement. So, we call them as forced expiration. That means, when you are throwing out all the air that we have in the lung, so we want to empty the lung cavity. If we are pressing this all these things forcefully expirating out or throwing the air out, we need this anterior abdominal wall muscle. That means external oblique, internal oblique, transverse abdominis and this rectus abdominis as well, contributing to this generating the negative intra-abdominal pressure by the contractions and creating a negative suction and throwing this particular air out from this. So, apart from this particular abdominal muscles supporting this abdominal cavity organs to hold that in position. It also helps us in forceful expiration. That's what we have to keep in mind. A kind of movement when we are born, we call this as a respiratory movement, abdominal movement. So, when we are born, just like a newborn, neonate, so you will see that this particular abdomen moves ups and down whenever it is respirating. Chest wall movement is relatively less. In case of the newborns, these intercostal muscles are weakly formed. They are not having that bunch of strong interthoracic muscles present. So, in this inborn, just newborn persons, we see these abdominal muscles are contributing for this respiration. That kind of respiration we call them as abdominal respiration. Then this particular respiration is partly contributed by these abdominal muscles and partly by thoracic muscles. We call them as abdominothoracic kind of movement. And a third variety, then we have this adult respiration, which is thoracic movement. Breathing in, breathing out is restricted principally by these thoracic muscles as it is growing strong. So, that kind of movement which is present in adult individual, we call them as thoracic kind of respiration. So, we have a terms of changes there. When you come to the pediatrics, we will talk about that particular thing. When that particular thing matters to us, again they have to come back to the abdomen and anatomy and physiology again whenever you are studying the respiratory movement for the kids, newborns, etc., etc. But coming to this particular region, as we are seeing here, the abdomen, which is point of concern, the cavity inside we call them as abdomen cavity, and inside of this abdominal cavity lined by a membrane we call them as peritoneum membrane. So, that particular peritoneum is lining or covering this undersurface of the diaphragm, is covering this particular abdominal cavity, and as well it is dropping down to the pelvic cavity as well, covering this entire thing inside. Now, this particular element, or we are talking about this abdominal cavity only for this, we are dropping this particular pelvic cavity. That does not mean that particular peritoneum is not existing in this particular pelvic cavity. We purposefully not mentioning about it because we do not want to complex these things right now. We are singling out the abdomen cavity. We will talk about this peritoneum things in the peritoneum classes, in the pelvic classes, sorry. Now, coming about this particular cavity, abdominal cavity, as I am saying, if you just like make a cross section, it looks like this. So, this anterior wall, lateral wall and the posterior wall which is visible through here is lined by this particular membranous structure, which is serous membrane, which is glistening white serous membrane which is present in here, which is covering this entire thing within this particular abdomen. We call them as peritoneum. Now, this particular peritoneum have got two layers. One layer we call them as parietal layer, other layer we call them as visceral layer. We are familiar with these words, parietal layer, visceral layer. We have learned that thing in the thorax as well. But again, to just like I talk about, the parietal layer is covering the body wall or this anterior abdominal wall, lateral abdominal wall and as well as posterior abdominal wall. That layer which is covering or layering or lining that particular abdominal walls, we call them as parietal layer. And another layer we call them as visceral layer, which is covering or present around those organs or viscera, abdominal organ, pelvic organs, whatever it is there, that particular visceral layer. So, these two layers existing inside within this particular abdominal cavity, making this particular abdominal cavity, everything here is abdomen cavity, and once inside here we line by this particular peritoneum, which is covering the parietal layer with this visceral layer, holds a cavity inside, we call them as peritoneal cavity. So, more or less this particular abdominal cavity is synonymous in broad sense with this peritoneal cavity. So, the cavity of the abdomen which is lined by this particular intric layer of the peritoneum, as such the abdominal cavity can be synonymously, or in a rough words we can say that they are more or less have got similar thing, abdominal cavity and the peritoneal cavity are same. So, the cavity whichever you seeing here, once you split through this particular muscles on the anterior abdominal wall is abdominal cavity, and as well as if you cut this particular peritoneum which is parietal layer, you get into the cavity of the peritoneum, we call them as peritoneal cavity. So, this particular peritoneal cavity, as we progress with this our lectures or the classes, we will see that have got subdivisions are there. So, this particular peritoneal cavity can be divided in the abdomen into two segments. We call them as greater sac and lesser sac. But by in terms, the lesser sac is a subdivision of the greater sac. We will talk about that particular greater sac and lesser sac about this pelvic cavity, peritoneum cavity as we progress. But we are getting into this particular layers first. We are going to talk about this particular layers, how these particular layers are placed. So, this is a sagittal section or side sections of this particular human individual. You seeing that from the sides and seeing these organs of the abdomen, how they are placed. So, this particular thing, whole thing out there is abdomen or abdominopelvic cavity. It is lined by two layers. One is purple, which you are seeing here. This is the peritoneal cavity all throughout. Now, you see that within this particular purple shade, there is a light purple shade which is existing onto this here. If you just like see that, in the upper limit we have this diaphragm. The lower limit we have this pelvic diaphragm, into which this particular pelvic organs are placed. So, entire thing, as we have agreed, we call them as abdominopelvic cavity. Now, we are just talking about the abdominal cavity above this particular pelvis here today. So, you see this large organ under the diaphragm is liver. Under to it, the liver, we have this particular tube like cavity which is large over here, we call them a stomach. These are the coils of small intestine which are present in different sections. The coils of small intestine are plenty. We call them a small intestine, large intestine, sigmoid colon, rectum, etc., etc. And as these things goes down with this anal canal which is going down like this, and along with that we have this pancreas, secretory organ which is present in here like that. So, this particular abdominal cavity can be divided into two broad things. We call this peritoneal cavity which is present in here in two broad names. This everything, all the abdominal organs is present inside this particular cavity as you are seeing here. We call them as greater sac. So, everything what you are seeing here is, we call them as this subcavity of this pelvic peritoneal cavity as greater sac. A small fractions over here behind this stomach and under this particular liver, this one we call them as lesser sac, also known as omental bursa. So, we broadly divide this peritoneal cavity into two entities, greater sac and lesser sac. Lesser sac is also known as omental bursa. This greater sac and lesser sac is divided in this way because this is partly hidden. So, if you go through the abdominal cavity, you hardly see this particular cavity existing. It is a kind of hidden or coop which is present behind the stomach and the liver and guarded and buried. So, that is why we have given a special name to it, and rest of this cavity we call them as greater sac cavity or greater sac cavity of this peritoneal cavity. So, within this particular peritoneal cavity which you are seeing here, the organ are placed. Now, these organs which is placed in here either covered by entirely by this particular peritoneum covering, we call them as intraperitoneal organs, or they are lying behind the peritoneum, just like inferior vena cava, superior vena cava, kidneys, they are lying behind this particular peritoneal cavities or peritoneal lining. We call them as retroperitoneal organs. So, this is how we are going to divide. Slowly I am coming into it, but this is the dispositions of this particular peritoneum layers and this particular cavity which you are seeing here. The peritoneum cavity we will talk about in the separate class, like next class. Today we will be focusing on this particular peritoneum and the layers of peritoneum we mentioned about. So, it is a peritoneum, it is a kind of like a membrane, transparent or semi-transparent, lining this particular inside of this particular layers of this anterior abdominal cavity which is present in here, had got two layers. We call them as parietal layer, parietal peritoneum, and other layer is visceral peritoneum. Parietal peritoneum is covering or lining this particular undersurface of the diaphragm and this body wall cavity, that means abdominal cavity, that means anterior abdominal wall, lateral abdominal wall, posterior abdominal wall, and this pelvic cavity too, they are covering it. The other layer we call them as visceral layer, they are covering these organs or viscera. So, this particular two layers, in between these two layers we have this particular space, we call them as peritoneal cavity, this peritoneal cavity which is existing on it. So, this particular peritoneal cavity have got two peritoneum have got two layers, parietal layer and visceral layer. Parietal layer, as it is covering this particular parietes, this is innervated by the somatic body nerves. That means the nerves which are mixed kind of nerves, that nerves which is coming from the spinal cords, they are supplying it. What nerve supplies to it? Phrenic nerve supplies to it. intercostal nerve supply. That means below 6 intercostal nerves, they are supplying to it. Subcostal nerve supplies to it. Iliohypogastric, ilioinguinal nerve, they are supplying it. So these are the nerves which is coming from this ilioinguinal, iliohypogastric, coming from a plexus, we call them as lumbosacral plexus. Just like brachial plexus as well, we have some plexus there. From there these nerves are coming. So you see that there are number of nerves. So phrenic nerve is supplying this particular peritoneum, parietal peritoneum under the diaphragm. This is the restricted region where you see this particular peritoneum under to the diaphragm is supplied by sensory supply is coming from the phrenic nerve. Now you see that so many nerves supplying this peritoneum. So that makes this particular peritoneum special in case of surgery. So if you are going to do surgery inside the abdomen and if you have to cut the peritoneum, so if you have to cut this particular parietal peritoneum, get inside, you see that how many nerves we have to anesthetize before you get into it. So many nerves you cannot anesthetize individually like one after another and you cannot track them. So that's why whenever we are going to do surgery, in case of the abdomen or abdominal cavity surgeries, we have to go for an anesthesia, we call them as general anesthesia. That means we have to anesthetize the whole body, the patient won't be able to feel anything, any consciousness won't be there. So that kind of thing, whenever you are going or breaching this peritoneum for doing any surgery, that's why we call them as this is a major surgery. So that's the difference between major surgery and a minor surgery is that whether you are breaching the peritoneum or not. If you are breaching or cutting this peritoneum, you have to take care of these nerves or else the patient will be feeling the pain. These nerves, so many of them cannot be anesthetized individually. That's why we have to anesthetize the patient generally. Go for whole anesthesia. That means we have to give the drug so that patient feels nothing. So he does not remember, recalls anything. So that kind of anesthesia is there. So if you are doing any surgery regionally, for example, draining this pulse space. So for pulse space infection, if you are just like going to do an incision, then you have to do a general surgery or a regional surgery. You will go for the regional anesthesia. We put the drugs around that particular nerve, 1 or 2, then we are good for doing surgeries. There because 1 or 2 nerves are supplying in here. And here out here we have nearly 10 nerves there. We cannot do that. So that's why that's a concept of general surgery and this particular minor surgery and the major surgery is coming on here. Whether we are going for general anesthesia or not, that decides on it. So this parietal peritoneum, which is supplied by the blood vessels as this parietes is supplying. That means anterior abdominal wall supplied by this particular blood vessels which is supplying this parietal peritoneum. The lymphatics is likewise and so is the nerve supply. It is sensitive to pain, touch, temperature, whatsoever there. So that's why this particular parietal peritoneum is sensitive to pain. Now having this particular parietal peritoneum sensitive to pain gives us a clue to the abdominal pains. That means if you have a pain which is related to this undersurface of the diaphragm, that will be radiating to the phrenic nerve domain. And we learned that phrenic nerve which is coming from the domain which is C3, C4, C5 over the tip of the shoulder. So any pain which is leading to irritations of the undersurface of the diaphragm will be heading to or referring to tips of the shoulder. So that's why we just like to see that if you have a localizations of that pain around this particular C3, C4 dermatome which is on the tip of the shoulder is probably related to the diaphragm or this particular region on this particular abdominal domain is concerned. So if we have any other pain which is other than this, we cannot localize this because so many nerves are there which is supplying to it. So that's why we, in case of the abdomen, we do not do any experimentations. We call this as a magic box because so many nerves are supplying, the symptoms which are present are given are often vague. So in case of the abdomen, just don't play with it whenever you have abdominal issues coming with it. So you go for directly doing for investigation and visualize the thing as quick as possible. Alright. So other than this thing very specific shoulder pain you are getting that might be related to the diaphragm or undersurface of the diaphragm, any abdominal pain go for ultrasound examination, CT scan, MRI, etc., etc. because the medical issues are very strong nowadays. So we cannot just like fall into soup, just like being very brave and identifying something like this is this and I understand this. you have this problem, but that turns up to be something different. So, in case of the abdomen, we call it magic box because often the clinical knowledge with these particular problems that we have. Coming from parietal layer, we have the visceral layer. This particular visceral layer covers the viscera. That means the organs that we have, that is wrapped by this particular layer, we call them as visceral layer. That means this particular layer which is covering the organ, it is getting the nerve supply from the organs. Most of the organs are receiving nerve supply from these autonomic nerves. That means they are insensitive to pain, and remember that I am using the word insensitive to pain. That means they do not feel anything, it is not like that. They are not feeling the pain, but they feel something, but the sensation is of course not the pain. You understand what I am trying to say? So, they are saying that insensitive to pain. It does not mean patient understands nothing. Patient understands something, cannot describe it properly as a pain sensation. Pain is the strongest sensation that is comprehended or that we understand very well. But in case of these autonomic nerves, they are receiving this particular sensation, but that is not pain is there. It is paining? No, it is not paining. Kosto hocche na, but I am feeling something which is there. Understand the differentiality with this insensitivity of the pain and no sensitivity. So, asensory means no sensation as well, but this is insensitive to pain. That means the difference is there, the pain feeling is not there. The blood supply is likewise the organs. So, if it is wrapping around this particular liver, it will be supplied by the blood supply from the liver or gallbladder or pancreas, whatever it is supplying or whatever it is covering to it. It will be receiving, and as well as the lymphatic drainage will be going likewise. We have familiarity with this same thing in case of this particular parietal layer of this visceral layer of this particular pleural as well. We have seen this particular distribution. So, of this peritoneum likewise is happening. In case of this particular visceral peritoneum, this particular pain or sensitivity is more direct compared to this particular parietal layer. In case of the parietal irritation, that cannot be pinpointed. In case of the visceral problem, that is more directed. In case of this particular small intestine problem, we get this particular foregut problem referred to this particular epigastric region of this individual. In case of this particular large gut which is having any kind of problem, which usually refers to the lower part of the body like pubic regions or this particular iliac fossa, etc., etc. If you have some problem related to the midgut, it refers to the umbilical regions if you have anything related to it. For example, if you have appendicitis. So, this appendicitis pain typically starts around this umbilical region, which is present on this midgut and this particular beginning of the cecum region. So, that particular pain sensation which is starting with this umbilical region later radiating or localizing to the right iliac fossa. So, that particular thing might give some clue, but again you cannot take chances with abdomen problems in case of diseases if had. So, if you have any kind of issues related to the visceral peritoneum, the pain sensation is there, isn't there, but there will be some sensation will be felt by the problem. It will be some referring to somewhere else. So, these are the two layers that we have, parietal layer and the visceral layer which is present to it. Now, this particular parietal layer and visceral layer, they are present around this particular cavities which is present inside the abdomen in the male individual and the female individual. So, before we move into the parietal modifications or peritoneal modifications, I am sorry, we have to understand these two basic steps about the peritoneum. So, in case of the male individual, as you are seeing in this particular individual over here, this particular peritoneum is sealed from above, sealed from anterior side, sealed from posterior side. Now, in case of the female subject, this is open in this particular region. How this is open? In case of the female subject, we have this particular birth tract which is present in here. So, this particular birth tract, if you have this particular cervix, uterus and the fallopian tube which is present inside. So, this fallopian tube has an opening which is known as tubal opening. So, that particular tubal opening has a natural opening which is leading or leaking into the peritoneal cavity or this pelvic part of the peritoneal cavity. So, that is why the infections from this particular female birth tract can climb up through this particular female tracts and reach to inside of this particular pelvic cavity. So, this is a uterus, this is how it looks like. So, this particular uterus is opening through the cervix and the vagina and to the exterior. The infection from the vagina can climb up to the cervix to this uterus and can come to this particular opening in here, which is opening of the fallopian tube or uterine tube. That fallopian tube is opening inside this particular cavity of this, as you seeing here, fallopian tube is opening inside the cavity of the pelvic cavity. So, it is possible in case of the female subject without having any breach in the peritoneum, infection can still reach to this particular pelvic cavity and abdominal cavity inside to it. So, that is why we call them as that this makes this particular female subject potential to have pathogens to enter without cutting or breaching this particular peritoneum directly. In case of the male subject, it is sealed or it is closed. So, there is a chances of natural infections to this particular male individual are less. In case of this female subjects, we have a trouble in terms of getting more and more abdominal pelvic infections. So, that is why we ask you a clinical question, explain why in female subjects it is more or prone to have pelvic inflammatory diseases or pelvic diseases. Explain why with your anatomical knowledge. So, we have to explain it why this is more common in female, that is less encountered in male subjects. So, this is the anatomical basis over here, that infection without cutting anything, we do not have breach of this particular content whatever it is. Peritoneum is intact in the female subjects, but it can reach inside this particular cavity and create a disease of this abdomen or pelvic organs by this natural tract which is present in case of the female subject. That is why they are more prone to have pelvic or abdominal pelvic infections. So, can you explain that with the anatomical knowledge? Yes or no? You understand how this infection in a female subject can naturally be getting inside the pelvic cavity or the abdominal cavity. So, you have to track the roots how this infection is coming and why this male subject is less vulnerable for such kind of infections. So, you have to justify in case of the male, this particular entity or this particular peritoneal cavity is closed. Why closed? We do not have any opening. So, parietal visceral layer which is sealed in here. In case of the female subjects, it is naturally open through this particular opening. Birth tract, like what are the tract? I have mentioned uterine cavity, cervix, vagina, infections can climb through. Clear? Yes or no? Good. So, going to this particular functions of the peritoneum. So, what this particular peritoneum is helping us to do? It is covering or wrapping this particular abdominal organs, giving it support. If it is covering this particular abdominal organ, tracking to this particular covering, the blood vessels and the lymphatics can reach to penetrate to the organs. So, the blood vessel runs within this particular peritoneum layers. That is what we are going to see. It can localize the infection. If you have an intra-abdominal infection, as we are mentioning, it can trap that infection, helps us to prevent some kind of diseases. It can hold some organs inside. That is what we are going to talk about, how it is holding some organ inside, and it can have a fat storage. So, in case of the extreme starvation, we have some kind of fat stored in here. So, we have some kind of energy preserved within this particular peritoneum layers for the future uses if required. Now, based on this peritoneum, how this is covering the organs, we can classify the abdominal organs into two entities. Intraperitoneal, that means it is completely buried within this peritoneal covering, or it is lying behind the peritoneum, that means we call them as retroperitoneal, just like retrospections. So, there are two entities how we can divide this particular abdominal organ. Either this peritoneum or this particular visceral layer is covering this particular organ completely, or it is covering or it is lying behind the peritoneum, how these things are there. So, either the organs may be retroperitoneal organs or intraperitoneal organs. So, completely covered by this particular peritoneum, covering is the stomach, spleen, liver, gallbladder, jejunum, ileum, transverse colon, cecum, appendix, so on and on. So, they are completely covered by this peritoneum. So, we call them as intraperitoneal organs. Some of them are not covered by this particular peritoneum, we call them as retroperitoneal. So, it is lying mostly behind this particular peritoneum. A part of duodenum, part of ascending colon, part of descending colon, pancreas, kidney, great vessels, that means inferior vena cava, abdominal aorta, and their branches, they are present behind this particular organ. We call them as retroperitoneal. So how these things looks like? We divide it into two subgroups. We call them as primary retro and secondary retro. What is that? I am just like mentioning it. So you have to know the examples of it. So best example you have to talk about this intraperitoneal organ is that the stomach and the spleen and the liver, you keep that in mind, and rest is coils of intestine, some of it. And retro, best example is that kidney and the pancreas, that should be sticking to mind about retroperitoneal organ. They are placed on the posterior abdominal wall. When you are going to do the dissection, that will be more vividly understood. So this particular peritoneum, as we are saying here, is present and wrapping in here. So you see that this particular duodenum is wrapped around this particular peritoneum. So as this particular duodenum is wrapped around this particular organ, this particular peritoneum or this particular pancreas slowly with development moves to the posterior abdominal wall. As it is moving to the posterior abdominal wall, a part of the peritoneum is lost, and resulting in this particular peritoneum, which is lost out here, this particular pancreas and the part of duodenum placed on posterior abdominal wall. We call this kind of organ as secondary retroperitoneal organ. What is a primary retroperitoneal organ? Kidney, aorta, inferior cover. They never had any kind of peritoneum. They are present behind this peritoneal covering. So we call them as primary retroperitoneal organ, kidney and this particular aorta. In case of the duodenum and pancreas, initially they had it, but they lost it. As this development is going on, this thing is moving backwards, they lose this peritoneum and paste it on the posterior abdominal wall. Deyale tangi deyar moto, it's hanging on the wall. That's why this is on the side, they are losing this peritoneum. This kind of organ we call them as secondary retroperitoneal organ. But coming again, we have two different organs to talk about, intraperitoneal and retroperitoneal. Primary and secondary, if you can remember about the retroperitoneal organs, it's good. If you just cannot remember, just stay quiet. Don't say anything about it. Alright? So, the organs which is peritoneal or completely suspended by this particular peritoneum can be hanged, like stomach, liver, duodenum, tails of pancreas, they are like intraperitoneal organs. Retroperitoneal, primary or secondary, their classification. You keep this particular chart for your reference. If you remember one or two like that, it's good enough. If you cannot remember, just like say about primary intraperitoneal and the retroperitoneal organ, kidney which is present in this particular region, and this pancreas, they are the two examples of the primary and the secondary retroperitoneal organ that holds the whole thing. Coming to this particular peritoneal modifications, as we are saying here, the peritoneum have got like a large length which is present in it. So this particular peritoneum goes for some modifications. Some of the modifications looks like fold, we call them as peritoneal reflection folds. Some of them, they look like ligaments, we call them as peritoneal ligaments. Some of them are known as peritoneum fold reflections or peritoneal reflections like that. So we are classifying the different types of modifications of this peritoneum in different three headings, and this is a complex part. This is your exam questions is about. So in exams, usually what we see that they ask about different kind of peritoneal modifications. The modifications of the peritoneum can be classified or sub-classified in three groups. Number one group, peritoneal reflections. Number two, we call them as peritoneal ligaments. And number three is peritoneal folds. These are the three entities that what we are going to talk about, the peritoneal modifications, right? So in examination, three of them may be there as an exam question, if it is a only peritoneum only questions, or any of them may be asked in examination. Discuss about peritoneal ligaments or discuss about peritoneal reflections, discuss about peritoneal folds. Any of them may be just like a given in examination with example and schematic diagram. We are just going to cover this peritoneal reflection for the day, which is easier because next day we are going to do this abdominal cavity dissection. So you will be seeing this particular thing in terms of reflections. So let us talk about the reflections. These are the reflections of the peritoneum. That means it is hitting some surfaces and changing the course. That makes this particular peritoneum reflecting towards others. Just like reflecting or reflections of light. If it is falling on some obstructions, it is shining it and then it is moving to different directions. If you follow this light as a particle, if it is hitting. So this is how this particular peritoneum is also hitting the stomach and then changing course. That is why it is known as the reflections of the peritoneum. So peritoneum or peritoneal covering hitting this particular stomach, making some changes, we call them as omentum. So there are kind of peritoneal reflection which is related to the stomach, we call them as omentum. We call them as greater omentum and lesser omentum. So these are peritoneal reflection or changes that is happening once this particular peritoneum hits this particular stomach. So there are two changes or two reflections that is observed in case of this particular peritoneum when it related to the stomach. When this particular peritoneum touches this particular small intestine, it also changes the course or it moves on. So that particular thing which makes this particular change, we call them as mesentery or the mesentery, which is related to the small intestine. When it touches this particular transverse colon, then it reflects to somewhere else. We call them as transverse mesocolon, which is related to the transverse colon. Sigmoid colon, which is the lower part of the colon, which is going to become this rectoanal canal, that part we call them as sigmoid colon. When this particular peritoneum hits this particular sigmoid colon, it becomes sigmoid mesocolon, and appendix we call them as mesoappendix. So these are the 6 peritoneal reflections that we are going to cover in this session. So quickly we go for this greater omentum. So stomach, if you see here, this is the stomach, this is the liver, it is on the top here, we have this diaphragm, right dome, left dome and central tendon in here. So stomach is placed on this particular region, right side of this under surface of this cavity over here, and farther on the left side of this cavity, and farther left out here we have this spleen present. So this particular stomach have got curvatures or bends. This curvature is short, we call them as lesser curvature. This curvature of the stomach is more, we call them as greater curvature. So these are the two curvatures are there. Hanging from these two curvatures, we have two peritoneal reflections. If we have this particular peritoneal reflection hanging out of this particular greater curvature, we call them as greater omentum. And on the lesser curvature, between this lesser curvature and this particular liver, we have a reflection, we call them as lesser omentum. So this particular peritoneal reflection which is related to this particular stomach, we call them as greater omentum and lesser omentum. They are present on two curvatures of the stomach. So let us take this particular greater curvature here. So this is the thing which you are going to see once you open the abdomen. So next day when you cut through the abdomen, you will see that once you open it, split open, you will see this particular curtain over here. It looks like an apron hanging down just like a drape falling from these curvatures of the stomach. This curvature which is attached onto top here, we call them as greater curvature of stomach. Lower end, it is hanging free. So this entire length of the peritoneum, which you have that fat and blood vessels and everything placed in here, we call them as greater omentum. So this greater omentum has an attachment above by this particular area, we call them as greater curvature of stomach. Lower end, it is free. So it hangs like an apron down there. It contains the blood vessel, we call them as right and left gastroepiploic vessels. This is what it supplying this curvature of the stomach. So when you are going to talk about the blood supply of the stomach, it will come to again. So this particular greater omentum or reflections of this is hanging down the stomach like this on the greater curvature. This greater curvature we call them as policeman of the abdomen. Why we call them as policeman of the abdomen? So if anything trouble happening inside the abdomen, this particular greater omentum which is hanging like a drape or apron moves to that direction. Say for example, this is the normal healthy thing of peritoneum, it should be looking like this greater omentum like this. So if you have an infection to this particular region, we call them as liver. So what happens here in that sense is, if you have infection on the liver, this particular greater omentum will be switching or moving towards this particular infection. So whenever you have an infection, say for example, if you have infection towards this particular spleen, it will be moving towards this left side and going to reach to this and even to cover this particular region and covers or wraps around the infection there. So it localizes the infection where it is there. So it's just like a policeman, it is present, plugs this infection. If you have anything protruding out, we call them as hernia. So if you have a hernia which is coming out, it tries to arrest that herniation and reaches to that particular point. So that's why you call them as this particular abdominal policeman. So it wraps around the infections, wraps around this any pathological thing that happens to this intra-abdominal cavity. So this greater omentum is a peritoneal reflection which is hanging down from this greater curvature of the stomach, which has a lower free margins, contains these two blood vessels and works as a abdominal policeman. This is in short 4 or 5 liner about this particular omentum. It is filled up with a fat and it has a peritoneal cavity occupied with this, preventing infections and running like this. So, this is how it should be looking like. Blood vessels should be visible like this. So, this is hanging from this particular stomach, greater curvature like this. This is about the greater omentum, and rest thing in dissection we are going to see. So, it can work as a policeman, it can work as a plugging of the hernial plug, it can be used for surgeries as well. During surgeries, if you want to repair something which you cannot repair with something else, we use this omental patch or omentum, greater omentum, for suturing things. So, for example, you see that this is a liver and this liver is badly injured out here. So, if you are going to stitch this to stop the bleeding from this particular region of this particular liver, what we do here, we take this omentum as a cotton piece, we piece it over here, place it within this particular wound and put a stitch or ligature on it. This particular wound stays there because of the nature of this omentum, which has a tendency to arrest some kind of problem or inflammation, it stays there. Otherwise, if you just like place a just direct stitch on it, it may not be sticking to it. Maybe it will be falling out, or maybe it will be creating much more trouble. That is why we keep this particular omentum as surgical patch. We call them as Graham's patch. In surgery, you will see that many times. You have the perforation of the stomach. See, stomach is perforated. So, that particular region also we take this particular omentum and we just like a stitch it and suture it like this. So, closure of these particular wounds, for that we use that. Sometimes this particular omentum, if it is going too deep or too into some like wild areas, it may be twisted. So, then we call them as torsions of the greater omentum. These are the clinical things that will be happening, or these are the clinical things that will be coming in a future days as well. But for now, we should be knowing what do you mean by the greater omentum, what does it contain. In red line it is written, you must not forget about this, these blood vessels, and the normal functions of this particular omentum is abdominal policeman. Year after, like last year or before year, we have this particular question, explain why. Explain why this greater omentum is called as policeman of the abdomen. So, this is the simple thing that we have written. You have to mention about what omentum is, what greater omentum is, and why this is called this thing. So, whenever you have infections, it moves to that side, tries to arrest this particular problem. If you have any herniations, it reaches to that. If you have any pathologies, it tries to move to that part and try to localize the problem that it has. Just like keeping this law and order in place, just like police people does. Coming to the other fragments of this, we call them as lesser omentum. So, we have the greater omentum which is attaching to the greater curvature of the stomach. So, you see that this greater omentum is stripped off, you do not see any greater omentum in this specimen. So, this is a stomach which has a greater curvature, this is a stomach which has a small curvature, we call them as lesser curvature of the stomach. So, in between this under surface of the liver and this particular lesser curvature of the stomach, another peritoneal reflection is there. We call this small peritoneal patch or membrane out here, we call them as lesser omentum. So, it is attaching on the under surface of this particular liver to this particular lesser curvature of this particular stomach. So, this particular entity we call them as lesser omentum. This particular omentum is small, short, and it is not having that much of free length so that it can move around. So, lesser omentum stays there where it is. So, it is present between the stomach and the liver. Now, this particular entity lesser omentum, as you are seeing here, can be divided into two parts. There are two subdivisions of that. So, a part is falling from this under surface of the liver to the lesser curvature. We call this part which is falling from the under surface of the liver to this lesser curvature, we call them as hepatogastric ligament part of the lesser omentum. And a part of lesser omentum is falling from this particular under surface of the liver to this first part of the duodenum. We call them as hepatoduodenal ligament part of the lesser omentum, and this is important. Again, this is very delicate regions conceptually. If you understand these things, it is easy for us to go for the rest of the things. So, lesser omentum is having two subdivisions. It can be split by these particular black dots that you are seeing here separating in two parts. It is coming from the undersurface of the stomach, liver, and falling on the greater curvature of this particular stomach. So, this part 1 which you seeing here, we call them as liver to stomach part. That is why you call them as hepatic to stomach gastric part, or this is looking like a ligament or kind of thready thing. That is why you call them as hepatogastric ligament. Other part which is part 2, which is having a window made out here. So, this part we falling is from under surface of the liver and falling on this first part of the duodenum. As the stomach ends, the small intestine starts. The first part of the small intestine we call them as duodenum. Duodenum can be divided into 4 subdivisions: part 1, part 2, part 3, part 4. So, this part 1 of this particular duodenum, which is present in this region, which is made a window out here, we call them as hepatic to duodenum, hepatoduodenal ligament. So, this is a 2 subdivision or 2 subpart of lesser omentum. Now, why this particular part 2 which you seeing here is split open in here? Because in this region you see that there is a window made here, and you can see that there is some kind of tube like structure existing on it. One is red, one is green, one is blue there. So, this region is immensely important. When this particular region is immensely important, you are going to do surgery to the gallbladder. So, you have an infection in the gallbladder, stone in the gallbladder, you want to remove that, throw it out. You have to remove this gallbladder out and you are going to do the surgery. So, how we are going to do the surgery? You have to stop the blood flowing to the gallbladder first thing, secure that particular gallbladder, or else before securing the blood vessel, if you cut the gallbladder, the bleeder will be bleeding out. So, you will be doing a successful surgery, but patient dies because of the intra-abdominal hemorrhage. So, for doing any surgery in the abdomen, we have to block the artery, block the blood vessels which is flowing through. That is the first thing. We call them as clipping of artery. So, the blood to the artery, blood flow to the artery, that branches which is coming in here, you have to click it. Second thing is that gallbladder is a storehouse of what? It is storing the bile. So, it is a temporary storehouse of the bile which is coming from the liver. So, from the liver, bile is coming and stored temporarily into this gallbladder, and then it is released from this gallbladder through the tube, we call them as cystic duct, into these particular tubes, we call them as the second part of the duodenum. So, the 2 things we need to secure if you want to do a surgery for the gallbladder. First, blood supply need to be clipped. Second thing, the outlet of the gallbladder, that is cystic duct, that also need to be clipped, or else it will be spilling blood. So, there will be a problem. So, how we are going to get this 2 structure in a single place? This is the place where you are going to see this structure placed next to each other. The blood supply to this gallbladder and this outflow tube of the gallbladder, which is the green one we are seeing here, we call them as cystic duct. So, this particular region, if you just like rip this particular lesser omentum hepatoduodenal part with your scissors or with your forceps, we will expose this, we clip this, and then we do the surgery, remove this diseased gallbladder out and suture it and leave it. So, this particular point, that is why we call them as free margin of lesser omentum. So, this margin you seeing here, which is not ripped in here, we call them as free margin of lesser omentum. So, this is attached margin, see that, and this is known as free margin because it is free, which is falling from the liver to the duodenum. So, gastroduodenal ligament part, you have to rip it, find this blood vessel, tie it there, take this diseased gallbladder out and suture it back and close the surgery. So, that is why this lesser omentum and this particular entities, hepatogastric ligament and hepatoduodenal ligament, that is a very important entity that need to be taken care of. This is number 1. Second thing, within this particular peritoneum fold, out here we have also a blood vessel present. As I mentioned, in this functions of this particular omentum really in the beginning is that this particular thing is carrying the blood vessels, lymphatics, nerves to the organs. So, each of these particular peritoneal reflections will be carrying blood vessels. Greater omentum carrying some blood vessels, lesser omentum carrying some blood vessels as well. The blood vessel which is carried through here is supplying these curvatures of the, call them as gastric arteries. Right side gastric artery, left side gastric artery, they are placed in here. So, whenever you are doing the surgery in the gallbladder, opening this region, you have to take care of few things. One thing, this content or blood supply of the gallbladder. Second thing, the outlet of this gallbladder, cystic duct. If you click this, and don't damage this particular blood vessel which is present in here, which is going to supply the stomach, or else you will be in deep trouble. So, we have to save this particular blood vessels which is present in this particular lesser omentum. We call them as right and left gastric vessels along the lesser curvature of the stomach. Lesser omentum and greater omentum, prepare that for the exam short notes. And why this particular greater omentum is called as abdominal policeman, provide your knowledge. Why this particular individual in the female subjects are prone to have natural infections which the male individual do not have, that propensities that we have to explain with your anatomical knowledge about closed peritoneal cavity and the open peritoneal cavity. Normal functions of the peritoneum and different layers of the peritoneum. Why this particular peritoneum, if you are going to do surgery breaching this peritoneum, why you have to go for a general surgery, a general anesthesia, explain why. So, with this particular explanation about so many sensory nerve supply to it. So, read this abdomen with this peritoneum. Next day onwards we will be going to do this dissections related to it. So, you will be catching up with these things more. So, next day we have to cover a lot about this particular rest of the peritoneum. So, I am just like giving you a quick briefing about this peritoneum. Rest of the peritoneum we will have to cover, like this one we call them as mesentery, transverse mesocolon, sigmoid colon. Then we have to talk about this particular peritoneal ligaments, that is why we are talking about, and the contents of the ligaments which is present in this particular ligaments. And then we have to talk about the peritoneal folds. Then we are going to talk about peritoneal folds to 8 parts of this peritoneum. We call them as greater sac and then lesser sac.